Hey everyone, welcome to Baltimore County Fire Department EMS Academy. For those who I haven't met, my name is Sean Barinholtz. I am an anesthesia and ICU physician at Johns Hopkins. I am an active volunteer at Pikesville Volunteer Fire Company, and I have the honor of serving as one of the associate medical director in Baltimore County Fire Department. On behalf of Dr. Andy Pollack and the medical director's office, on behalf of the EMS office, Director Shenning, Captain Stewart, Captain Nats, thank you for what you guys do every day. Thank you for your dedication to lifelong learning. A big shout out to Ashley Brooks, who is a young member at Pikesville Volunteer Fire Company, who is helping us with our live stream technology. Ashley is also the one who is going to send out a link in the chat. That link is where you can sign up to get your MIM CEUs. So if you want your MIM CEUs, keep an eye out. Sometime during this training, Ashley will put a link. We'll also make sure that I announce that at some point in time as well. Great. Okay, so tonight, just absolutely delighted and excited to hear and to learn from Dr. Peter Crino. Dr. Crino is a professor and chair of neurology at the University of Maryland, Baltimore. Dr. Crino received his medical degree from Yale University, his Ph.D. in neuroscience from Boston University. He completed a medical internship at Yale-New Haven Hospital and neurology residency at the University of Pennsylvania with clinical training in epilepsy. He is dual boarded in neurology and EEG. Dr. Crino, thank you for being with us. Thank you for sharing your time and your expertise.
Thanks very much for the kind introduction, Sean. It really is a pleasure for me to be here. And good evening, everyone. I am so sorry that I couldn't get to meet many of you in person. It would have been really an honor for me to get a chance to meet you and chat with you. But in this crazy COVID Zoom world now, this is the way we have to roll. So my sincere apologies. And let me just say, let me also echo what Sean said. My thanks to you for your real service. It really is quite a thing that you do. So in my little small corner of the world, I'll try to impart to you some knowledge that hopefully will help you practice better when you engage with individuals out in the community and are faced with challenging situations. I'll try to help you understand a little bit about what seizures are and what epilepsy is. These are very, very common disorders. And I'm sure many of you, if I just asked for a show of hands or, a little emoji on the screen, if I said, how many of you have ever seen someone have a seizure or how many of you know someone who've had a seizure, my guess is a lot of you would raise your hands. It's pretty common. Yeah, I'm seeing a lot of thumbs up and hand waves. So what I'm talking about is a fairly common medical challenge. Certainly first responders are indeed faced with this all the time. And the big challenge is understanding, is this just a single seizure or is this reflective of the greater disease, which is called epilepsy? And we'll try to thresh that out a little bit. The forum I'd like to use for tonight is we will chat a little bit about seizures and epilepsy. I'll talk with you a little bit about, just so you understand the disease a bit. We'll go on to talk a little bit about kind of the first aid and sort of first responder posture. There's actually on the Epilepsy Foundation of America, there's actually a web page which talks about the appropriate first responder posture, and really anyone who's out in the field can take this strategy. And then what we'll do is at the end is either chat or people can raise their hand. We can have a nice open discussion. I'm happy to answer literally any question that you might have. So I'm just going to start. This is my home institution and also Dr. Pollack's home institution. There's our hospital over here. This is the original medical school. It's really been a privilege to serve as chair of neurology here now for 5 years. So I want to talk to you a little bit about seizures and epilepsy. And seizures are just incredibly common events. And as we've heard, many of you have seen people or know people who've had seizures. And, if you look at the incidence, just the number of people who've had seizures, 80 per 100,000 per year, the lifetime prevalence of having seizures is about 9%. So again, pretty common. And then what's really sobering to me is when you start realizing that, when you think about epilepsy, and epilepsy is the condition of spontaneous recurrent seizures, where you begin to have seizures over and over again. This is a very common neurological disorder. It affects about 45,000 per 100,000 per year. The actual estimated prevalence in the population is about 1%. 1 in 100 people walking around has epilepsy. And the Institute of Medicine, the IOM, which looks at these kind of statistics, says that about 1 in 26 people has epilepsy. And so the way I like to think about it, now I got to tell you folks, I'm from Jersey, so I'm a Phillies fan, but we can talk about the O's if that's okay. You know, if we think about an average glorious night at Camden Yards, we think about a full stadium here, it's really pretty sobering to realize that, you know, honestly, if the capacity of that place is 48,000 people, there's about 400, almost 500 people there who are potentially at risk for having seizures. And then if you think about it, which I'm sure you're all aware, some of the known risk factors for seizures, not the least of which is drinking alcohol. It's amazing that we don't have a veritable epidemic of seizures during every professional sports event, quite frankly. Every time I go to Citizens Bank, I always look around and I just say, wow, it's just incredible how prevalent this neurologic disorder actually is. So what is a seizure? What happens during a seizure? And then I will try to take you from seizures to epilepsy. So a seizure is a very generic term for a group of neurons in the brain. These are the cells that make up your brain. They are electrical cells that begin to fire electrically in an abnormal pattern, in a way that they're not supposed to. So seizures are really an electrical disturbance of brain function. There's many different types of ways people experience seizures. There's many different types of presentations of what seizures look like. And at the end of the day, it's often a clinical diagnosis. So we hear a story of someone who says, you know, I was at work and I felt this funny feeling in my arm, and then I noticed my right hand begin to twitch. Next thing you knew, my right arm began to twitch. And then the next thing you know, I woke up and all of my colleagues were leaning over me and they were saying, are you okay? Are you okay? So when we hear that history in the office, we often have to sort of do a little detective work and try to figure out, you know, do we think that was a seizure? Was it some other neurological event? You know, a lot of you, I'm sure, when you think about sort of the things that people can show up with out in the field, you think of, well, is it a seizure or is it a stroke? You know, one simple thing about strokes usually are due to damage in the brain. And so as a consequence, patients usually will present with stroke where they kind of lose function. So they are paralyzed on one side, or they lose vision, or they lose speech. Seizures is a little different. Usually they do something new and different, such as twitching or stiffening of a limb. Their face twitches, their whole body shakes all over. So it's sort of active, more dynamic symptoms as opposed to a stroke, where it's usually a loss of some kind of neurological function. So let me take you inside the brain here. So this is an MRI scan of a human brain. And if we were to actually look at what a brain looks like, this is what the actual human brain looks like. All these foldy things here. This is a part of the brain that's called the cerebral cortex. And that's the part of the brain that allows us to move and to see and to really think and be who we are. The cerebral cortex, if we were to look under a microscope, is made up of these little cells here, which are called neurons. These are electrical cells that basically are the cellular workhorses of our personality, of our ability to think, of our ability to do our jobs, and really do everything that we do. Now, if we take sort of a schematized diagram, neurons or nerve cells, they talk to each other by electrical communication. They literally touch like this and they communicate electrically. When that pathway, when that process of electrical communication is disrupted, one of the results is a seizure. The person will begin to have discharges in the brain that cause a clinical manifestation. And whether it's twitching of a hand, twitching of a face, or the whole body shaking, that's reflective of abnormal neuronal activity in the brain. Now, anyone can have a single seizure. So someone who has extreme alcohol intoxication, a person who's exposed to a poison like carbon monoxide, a person who has too much of a particular type of antibiotic can have a seizure. People who have extreme sleep deprivation, a traumatic brain injury, a brain tumor, anything can cause a single seizure. But a single seizure is not the same thing as a diagnosis of epilepsy, right? In order to have epilepsy, you have to have seizures. But it's important to realize that just having a seizure does not mean that you have epilepsy. And many people will just have one seizure. In fact, anybody can have a single seizure. It's not uncommon that I get every year at the end of the semester, I'll see a patient from College Park campus or UMBC campus who's pulled an all-nighter and then has a seizure on the day of their final exam. And that's just because of sleep deprivation. So it's important to realize that in order to have epilepsy, you have to have recurrent seizures. but just because you have a single seizure, that doesn't mean you have epilepsy. So what's the diagnosis of epilepsy? Well, epilepsy is a disease. And as I said, a seizure is the clinical manifestation of an abnormal neuronal activity in the brain. In order to have epilepsy, you simply have to have had 2 unprovoked seizures occurring greater than 24 hours apart. If you have that, you have epilepsy. So it's a pretty simple distinction. A lot of times you'll hear people talk about someone has a seizure disorder. Really, they just have epilepsy. That's just kind of the name for it. So again, a single event that you might witness in the field, that's a seizure. If that's in a person who has a history of epilepsy or recurrent seizures, it's important for you to know that as a first responder. A first-time seizure could be alcohol intoxication. It could be a toxic exposure. It could be not enough oxygen to the brain. But a seizure in a person with epilepsy may be that they forgot to take their medicines, or that they were exposed to some kind of metabolic abnormality that's made it more likely to have a seizure. So it's important to kind of understand this. Now, the terminology for different types of seizures, we used to have an old terminology, some of you may have heard of it, which is called a petit mal seizure, which kind of means it's maybe not that bad a seizure. And then a seizure called a grand mal seizure, which is like a big bad seizure. And worst of all was seizures that we used to call idiopathic. And whenever doctors say idiopathic, it just means they're using it where they really don't know what's going on. And so we've kind of done away with these technologies now, and I won't belabor this, but we have more traditional classification now of simple seizures, complex seizures, and so-called generalized seizures. And in fact, now we have this, and obviously don't need to know this, but we have all different types of seizures, focal seizures, generalized seizures, all different types of epilepsies. And what I want to point out over here is that there are many, many causes. So an etaology is a cause of a neurological problem. There's things like structural abnormalities, infectious diseases, changes in your electrolytes and your metabolism, and immunologic changes. So there's lots of different seizure types, and there's lots of different epilepsy types. Now, suppose you're out in the field and you see a person who is standing there and they suddenly drop to the ground. Well, the list of things that can cause that is actually a few. So many of you have heard of something called syncope. Syncope is the medical term for fainting or passing out. And oftentimes people who pass out are mistaken for having had a seizure. So they will suddenly maybe stagger a little bit and then collapse to the ground. Some people, as I mentioned before, in stroke will have a massive stroke that will render them unconscious, and they will just simply fall to the ground. People who have seizures that are accompanied by a change in mental status, so they appear confused or delirious or disoriented. Oftentimes they're mistaken for people with psychiatric disturbances, or often, worst of all, people who are using illicit substances. And I'll show you later, there's many, many case reports of epilepsy patients out in the field who have been misrepresented or inappropriately assessed as being either criminals doing criminal activities or being under the influence of drugs. And quite simply, they were just having a seizure. So it's important to realize that not everything when someone falls to the ground and shakes all over is necessarily a seizure. Some seizures start in a particular part of the brain and can spread to the rest of the brain. Some of them at their onset just start all of a sudden and they just extend through the entire brain. A generalized seizure is a seizure that infects the entire cerebral cortex, and usually the person is having symmetric whole body jerking or shaking. They are unconscious by definition. They will not communicate with you. They will not say anything. The typical duration is about 1 to 2 minutes. And after they have a seizure, most people are pretty out of it. They're pretty lethargic and confused. Many just want to sleep and be left alone. And so when you see a generalized tonic-clonic seizure, it's often something that you don't forget. Now, sometimes seizures will start as generalized seizures, and sometimes they will start as partial seizures. And so what I'd like to do here, if it's possible, I'm just going to stop sharing my screen for 1 second. And I just want to show you an example. So this is, let me see if I can do this real quick. Dun, 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 dun. So here's a patient, and this patient has consented for the use of this video. This is a person who's in the hospital who's being recorded. And here you can see, are you able to see that and hear that, everyone? Yes, give me a thumbs up, maybe. Great, thank you. All right, so he's just kind of sitting there, not bothering anybody. And you can see him, he's sort of staring right here, and he gets very quiet all of a sudden. Now you can see how he's looking off to the right and his right hand comes up. Now you'll listen to this noise. And this is a pretty classic generalized tonic-clonic seizure. So this first phase is the tonic phase where he's completely stiff. It looks like he's not breathing. In fact, he's not actually breathing. And you can see how his whole body is stiff. And this will last for a period of time. And then he'll go into something called the clonic phase where he'll begin to have shaking movements. And the shaking movement really is not shaking like this. It's actually him stiffening and relaxing, stiffening and relaxing. If you feel him, he's stiff as a board right now, stiff as a rock. And now this is just physician coming in to check on him. This is in the hospital. And the key thing to realize is that most of these seizures last about 1 to 2 minutes. About 80% of seizures will stop in about 5 minutes. A seizure that goes on for longer than 5 minutes is very worrisome and very concerning as someone we would need to get sort of into the EMS system and get to a hospital. And you can see he's starting to slow down. After people have a seizure, they will often have very, very deep and sort of phlegmy sounding respirations. They will often have sort of a gurgling sound, and it's very, 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 very frightening. And that's why you see them turning him on his side. And we'll talk a little bit more about this shortly. So I just wanted you to have that example in your mind. All right, let me keep going. Okie doke. So we use a test called the electroencephalogram, or the EEG, to diagnose a seizure. And basically what it does is it just records brain activity. And you don't have to be an EEG expert to understand that this part of the brain is actually acting normal, but this part with all the squiggly lines, that's where a seizure is happening in the brain. And when it spreads to involve the entire brain, well, really the whole brain is affected. And I'll show you an example of that. All right, here's an example of the EEG where the entire brain is affected, like that individual that I just showed you. And again, when you're having that kind of a seizure, a generalized tonic-clonic seizure, you are unconscious, you're not able to communicate. If you shake that person, they are unresponsive. And only when their seizure is over can you begin to sort of do something for them that might kind of help them in terms of first aid and maybe communicate with them. Now, we know that there's a lot of different causes of seizures, and some of them are really linked to age. So we know that infants and young children, prenatal or birth injury can cause seizures, congenital malformations of the brain and body can contribute. There are certain genetic to this. As you get into adolescence, especially in adolescent boys, we have things like trauma, like motor vehicle accidents, falls, things, sports-related injuries, where there's an injury to the brain, and that may cause a seizure. Infection, things like meningitis and encephalitis can also cause seizures. As we get into adolescence and young adults, again, particularly in young males, things like MVAs, violent crimes, sporting events can cause head trauma, and having a head trauma can absolutely cause a seizure and can lead to epilepsy. As many of you may know, we see the sort of the 18 to 30 demographic is often a time where we see drug intoxication and withdrawal symptoms from a variety of illicit substances. Actually, amazingly, despite all that's out there now about the opioid epidemic, opioids are an uncommon cause of seizures. And actually, the big one still today, believe it or not, is either acute alcohol intoxication or in someone who is a substance abusing alcohol person. When they withdraw and try to come off of their alcohol, you may see seizures. And then in older adults over the age of 65, other things like strokes, brain tumors, neurodegenerative disorders like Alzheimer's disease can increase the risk for seizures. So you can see it very much is kind of time linked from infancy all the way through to older age groups. Now, when you see a person who's having some kind of an event, you actually have to ask yourself, like, well, do we think this is a seizure, or do we think it's a pass out spell? Do we think the person's having a stroke? Do we think it's some kind of a tremor? Is it some kind of a twitch kind of a thing? So it's important as a first responder, when you see this, to first of all, think of the diagnosis. If someone is not speaking or thinking correctly, or they're not acting correctly, or they look like they're disoriented or confused or delirious, think about the possibility that they're having a seizure. And then decide, is there something going on in this person? Do we think that maybe they're intoxicated on drugs? Do we think that maybe they've had a head trauma? Do we think that maybe there's been some kind of toxic exposure for them? So in the average everyday person who does not have epilepsy, what are some of the things that can precipitate a seizure? What are things that can cause a seizure? Well, any kind of metabolic or electrolyte imbalance, whether it's your sodium or your calcium or your level of sugar, people who have diabetes who take too much insulin or too much of a type 2 diabetic medication can lower their blood sugar precipitously, and very, very low blood sugar can be associated with seizures. Some kind of withdrawal from their medications can certainly do it. So people who take seizure medicines, who forget to take their seizure medicines, often will just have a seizure as a consequence. People who take stimulant medicines like amphetamines, methamphetamine, cocaine, those can predispose to seizures. Those are what are called proconvulsants. They make the brain want to have a seizure. As I mentioned, alcohol withdrawal or ethanol withdrawal is a very common cause of seizures out in the field. Believe it or not, as I mentioned, extreme sleep deprivation in some individuals can render them more susceptible to seizures. In female patients at or around the time of the menstrual period, there is an increased susceptibility or sensitivity to having seizures. Obviously, having a menstrual period by itself is not enough to cause a seizure, but if you are in a situation where you might be at risk for that, or if it is a time where it is the time of menses, and for example, you are going through alcohol withdrawal, well, that's kind of two things that can contribute to it and make seizures happen. Extreme stressors and systemic infections can also predispose individuals to have seizures. I see the patients after they've been brought in to be evaluated either in the emergency department or if it's as an outpatient when I see them in my office, just so you know what the standard workup for a seizure is as well. It's a history and physical. We do a number of blood tests to make sure that electrolytes are normal, to make sure that their blood count is normal. If we suspect that they have meningitis, which is an infection of the lining of the brain and the spinal cord, we will do a test known as a spinal tap or a lumbar puncture, where we sample some fluid that surrounds the brain and the spinal cord. And then that would be an indication to treat with antibiotics. We always do a tox screen in patients that come in looking for, the usual suspects. Amphetamines, methamphetamines, narcotics are usually on there, alcohol, etc. Because frequently in the community that we serve, this is often a cause for a first-time seizure. As I mentioned, the electroencephalogram or the EEG, which is basically a test where we put wires on the scalp and we record brain activity for about an hour. And every patient who's had a single seizure, according to the American Academy of Neurology diagnostic criteria, has to have some form of brain imaging study, which is either a CT, which is computed tomography, or MRI scan, magnetic resonance imaging scan, to actually look at the structure of the brain. Remember, a person who has a brain tumor, they might present with a seizure. So they don't know they have a brain tumor until they have a seizure. They get brought into the emergency department, we do our evaluation, we get a scan, and we find that they've had a brain tumor. So seizures are often heralding presentations for neurological problems. People who've had bleeding inside of the brain may also present with a first-time seizure. So seizures are important to recognize, not only because they are sometimes indicative of a substance abuse or a toxicology exposure, but also because they can be heralding features of a neurological disease. The decision to treat patients with seizures, this is something that a primary care doctor or a neurologist or an emergency room physician will consider. And it's a challenging thing to decide. Roughly about maybe 30 to 50% of people, if I think about the average, will have a second seizure if they're not treated after their first seizure, which means that there's a fair number of people who won't go on to have a second seizure, but a fair number who actually will go on to have a second seizure. So it's a little more challenging to try to figure that out. So I'm just going to pause for a second because there's two questions here. What about excessive use of energy drinks like Red Bull? So that was from Joe Benham. Joe, I hate to tell you this, but yes, absolutely. Excessive consumption of Red Bull absolutely has been linked to people having single seizures. And as a matter of fact, believe it or not, when we have people in the epilepsy monitoring unit in the hospital to try to capture their seizures and do recording on them, if they go a few days without having seizures, we actually have them drink a couple of Red Bulls. So yeah, it absolutely can happen. Someone else asked the question, what about testosterone over the counter? No, there's no known association between testosterone-like drugs, androstenedione, and any of the other DHEA kind of compounds with seizures. So nothing that I'm aware of. What about coffee? So coffee, no. Coffee is a gentle stimulant in the kind of the pantheon of stimulants. It's actually a pretty, pretty mild stimulant. So no, we don't worry about that. Can I discuss use of paramedic with Versed? I will come to that in a little while, if that's okay. Any other common everyday items? Actually, not really. You know, there's some evidence that some antibiotics may put people at risk for seizures, but the evidence is a little squishy. There's really no evidence that any particular foods cause seizures. There's no evidence that too much sugar, none of that stuff. So there doesn't seem to be anything that we do in our diet that necessarily predisposes people to seizures. All right. So we have to make a decision about whether to treat people. And so after a first-time seizure, we often decide to wait and see if they're going to have another one. If they have a seizure and we get a scan and they have a brain tumor or they have some kind of structural abnormality in the brain, then often we do decide to treat them because remember, that abnormality is going to be there and we don't want them to start having lots and lots of seizures. If we see an abnormal EEG, the brainwave test, we often will start medications, and if patient's family history is very strong for seizures, we'll also consider starting medications. I wanted to just let you know there are the words, the terms that we use. Anti-seizure medicines are actually called anti-epileptic drugs. There are many different types of anti-epileptic drugs, and I'll show you. You don't obviously have to know all of these, but just so you know, there's an awful lot of them that are out there on the market. And it's important when you see a person in the field and you're thinking that they might have had a seizure or they might actually still be having a seizure, that you check for a medical alert bracelet, because medical alert bracelets or medical alert necklaces often have the listing of what seizure medicine is there. And so, you know, think about it. If you see someone who is acting strange or maybe looking like they're disoriented or confused, and you check and it says carbamazepine and topiramate, well, that helps you realize that this person has a history of epilepsy and they are very likely having a seizure or maybe just coming out of a seizure. And it's going to very much change your approach to how you care for this person. All right. So things that we can tell people, and this relates to some of the questions that were just posed in the chat box. You know, obviously, if people have a history of epilepsy, recurrent seizures, we tell them to, you know, get good night's sleep, good sleep hygiene, to avoid excessive alcohol and things like Red Bull, and obviously illicit substances like amphetamines and things like that. Try to avoid any known precipitants. Some people will say, look, I only have a seizure if I stay up all night to fly on an airplane, or I only have a seizure if I take a certain type of antibiotic. Those are easy things to sort of modify in terms of lifestyle. And yeah, stress reduction does work. It won't cure your epilepsy, but it might reduce the likelihood that you'll have subsequent seizures. So I just wanted to give you a sense kind of what the standard of care is in terms of how we practice and how we assess patients. I also wanted to tell you that some people don't respond to medications, and this is important to keep in mind. Some people, no matter how many medicines we give them, and let me tell you, I have people who are on 5 and 6 of these medicines and still are having pretty aggressive seizures. There are other things that we need to do. So believe it or not, there's something called neuromodulation, and there's brain surgery for epilepsy. Neuromodulation, there's 2 devices. This device here is called the vagus nerve stimulator, which is actually like a cardiac pacemaker. It's implanted in the chest and it sends electrical impulses via a wire that connects up to a nerve in the neck that goes into the brain, and it modifies brain activity. And then there's this device here, which is known as NeuroPace, which is the responsive neurostimulator, which, believe it or not, it sounds like science fiction, but this is actually a mini computer that's loaded with AI, artificial intelligence software. And that software controls this electrode here that's implanted in the brain. And what happens is this electrode actually senses when a seizure is going to happen. It sends the information back to the computer, and the computer interprets it as a seizure, and then, believe it or not, delivers a counter electrical stimulation to stop or abort that seizure. It doesn't work in anyone, but in everyone rather, but the few people it does work in, it actually seems to work spectacularly well. And then and this is what it looks like when we deliver the stimulation. We can actually stop a person's seizure, which is pretty amazing. And this is actually a recording right here of the therapy when it goes. Here's the seizure right here in blue. This therapy, the device turns on, and you can see the blue just goes away completely. So it really does seem to work for some people. And then epilepsy surgery, basically it's removing a piece of the brain that's causing recurrent seizures in people. And we do an extensive evaluation before the surgery that includes EEG and MRI and PET scans and a whole bunch of different approaches. And it's basically this: we go in and we open up the skull and we find the spot in the brain that we think is causing the seizures. And here, for example, this person in the brain, this part of the brain is causing seizures, and we simply remove that piece of brain to help cure their epilepsy. In the right person, it's curative in about 70% of people. So it's actually a remarkable way to actually treat epilepsy. All right, let me do these last two slides and then I'll answer some questions. I mentioned before that the average seizure duration is usually 1 or 2 minutes, and 80% of people will stop having a seizure after about 5 minutes. The definition of something called status epilepticus, which is basically the condition of ongoing non-stopping seizures, is defined by a seizure of more than 5 minutes. So you can imagine the gentleman that I showed you before having that convulsion and having it go on and on and on for 5 minutes. And I'll do something with you that I do with my residents in the hospital, because they often say to me, they say, well, it doesn't seem like that much time. So let's just try something right now. I'm going to go on my phone real quick. And I'm just going to set my timer real quick. And here we go. You ready? We're going to start. 1 second, 2 seconds, 3 seconds, 4 seconds, 5 seconds, 6 seconds, 7 seconds. You get the picture. So imagine the person having an ongoing generalized tonic-clonic seizure, whole body seizure for 5 minutes. That's a medical emergency. And that's a scenario in which we need to think about giving people rescue medications to stop it. Someone alluded to Versed and asked about that a little while ago, which is midazolam, often used in the field. And there's been a number of protocols now in EMT and EMS to use in the field medications, as many of you I'm sure are well aware, for cessation of seizures out in the field. So not waiting for the person to get into the ED, but actually going ahead and giving them either midazolam or Versed or Veltoco or whatever medicine there is to try to stop the seizures in the field. And this has been amazing. It's made an incredible difference in how well we are able to take care of patients. Status epilepticus is in many ways like cardiac arrest. It's like a stroke. It's like a myocardial infarction or a heart attack. It is a medical emergency, and the goal is to stop the seizures as soon as possible by any means that you can, and get the person into an ED so they can get an IV and get other anti-seizure medicines going. All right, I'll pause here for a second, and it looks like I got a couple of questions in the chat, so we'll pause here before I go on. Okay, so what are the different types of seizures and how do they affect patients? Well, I showed you earlier on, there's really two broad types of seizures. There are partial seizures and generalized seizures. Partial seizures are seizures in which a person may be sort of acting strangely. They may appear confused or disoriented. They may be saying odd phrases and look kind of like they're spaced out, but they're still awake, looking around and interactive with the environment. In a generalized seizure, a tonic-clonic seizure, as I said, the person is unconscious. They're out on the ground. You can't stand up and have a generalized tonic-clonic seizure. You fall to the ground. You often injure yourself when you fall to the ground. So partial seizures, the person is sort of awake, but very confused or disoriented. Generalized tonic-clonic seizures, they are unconscious and on the ground. The last device is used in the hospital, right? Or is this used out of hospitals? No, it's actually used outside of hospitals. We implant that device in the skull. The wire is implanted in the brain. It is indwelling, and yes, you go home with it. It's really, really quite remarkable. Question here, what are the current medical thoughts on cannabis? Well, cannabis is not really an option for therapy for seizures. There is a derivative of cannabis, which is known as cannabidiol. Cannabidiol is one of the 400 compounds that are extracted from cannabis. When it's made in a pharmaceutical grade purified form, cannabidiol actually does work to help cure epilepsy, but it's a very specific type of epilepsy, a genetic epilepsy called Dravet syndrome. And so it really, the idea of using cannabis to treat all kinds of epilepsy has not been borne out by studies, but in a few very select types of seizures, cannabidiol, a derivative of cannabis, works actually quite well. What are my thoughts about those portable headband EEGs used out in the field? Well, they were, as you know, they were developed for use in the military space. And they are designed to rapidly put on an EEG, identify whether a person is having a seizure, take it off and get the person to a medical field hospital. Right now, in most major hospitals, the use of regular EEG, where we use the standard kind of approach, I think makes the headband EEGs less useful. I think out in the field, they are potentially of some use. They are still kind of expensive because the headbands, as you know, are not reusable. They're disposable. So they may be out of the budget for many first responder situations. But I think there's more to come. Right now, we're calling them reduced montage EEGs because a standard EEG has upwards of 30 or 40 electrodes. The headband EEGs only have 8 electrodes, and it gives you a very limited coverage just around the temporal lobes. So in certain spaces, I think the military space, potentially out in the field, there may be some utility. There's still work to be done to figure out just how effective they're going to be. Someone asked, with the brain surgery option, how affected is the person afterward? Amazingly, people go on and live full lives because the idea is that the part of the brain causing seizures is just kind of a dysfunctional part of the brain. It's actually compromising the function of the rest of the brain. People go on and they have great, success. They get married and, have jobs and do all kinds of stuff. So it's actually pretty amazing surgery. I'm going to come back to the Versed question in a little while. Can someone in status epilepticus injure themselves? Yeah, they absolutely can. So when a person's having a convulsion, as I showed you in that guy before, if their tongue is caught between their teeth when it starts, they will bite their tongue hard. If they're standing up and they fall into the stove, they're going to burn themselves. If they're working as a cook in a restaurant, they're going to burn themselves. Heaven help me, if they're taking a bath, they're going to drown. If they are driving a car, I have personally stopped to help 2 people having seizures at the wheel of a car. It's always bad, and it's always a bad accident. So either a single seizure or status epilepticus, absolutely you can injure yourself. Is there anything you can do to prevent a partial seizure from going on to be a generalized seizure? That's a great question. And sadly, the answer is not really. Sometimes you can give a rescue medicine and it will prevent the seizure from going on, but usually that passage from partial to generalized seizure happens pretty fast, on the order of like less than a minute. So by the time you get all the meds ready to go, and I've had this from patients who say, God, we had the midazolam drawn up and ready to go, we just couldn't get it in fast enough. So it's often a little challenging to do that. All right. Last question, a patient who has what appears to be a tonic-clonic reaction or episode in what is an otherwise syncopal episode, think post-blood draw, is that technically a seizure event or physiologically unrelated? A syncopal event, a pass-out event, is not a seizure because it's not caused by recurrent abnormal electrical activity in the brain. A pass-out event or a syncopal spell is caused by not enough blood getting to the brain. Now, every now and again, a person who has a syncopal spell, when they pass out, will have a couple of quick jerks like this, and then they will stop. Still not a seizure. That's because there's not enough blood flow getting to the brain. All right, I want to share with you something that I think you'll find also pretty intriguing, which is something that's known as psychogenic non-epileptic seizures. And these seizures are very interesting. I'm just trying to move this out of the way so I can actually just move my screen around here. Dun, 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 dun. Sorry, here we go. And these are seizures that look like seizures and are often misdiagnosed as seizures. They are often indicative of psychological stress, often seen in individuals with physical, emotional, and past history of sexual abuse that look like they're having seizures, but actually they're not having a seizure. If we were to record an EEG on them, we wouldn't see a seizure. So I'm going to go ahead and show you something to see if I can get the point across to you, because it's useful. Okay, hang on one second. Mm-hmm. Mm-hmm. Okie doke. So I want you to take a look at this gentleman right here. And this is why my job keeps me up at night. So here's a gentleman who's also in the hospital, just like the last person that I showed you. And here he is. And are you able to see and hear everybody? Okay. Thank you.
I can see.
Thank you. So now you can see him. He's kind of sitting there and sort of blinking and staring off, closes his eyes, and now he starts shaking. Now you'll notice in this shaking spell, he's doing sort of rhythmic jerking like this, back and forth and back and forth. That's very different than the first one I showed you, where the person is completely stiff and just having intermittent kind of jerks. This sort of rhythmic stopping, starting, kind of side to side sort of movement is very classic for what's called a psychogenic seizure. So this is a seizure where the person is actually, if we record the EEG on them, we actually don't see a seizure there. And in fact, this event is a psychogenic event. It's a psychological event. And this can be tricky to figure out. I have personally misdiagnosed a couple of these in my career, and you know, it can be pretty challenging to figure out. Now, I'm going to show you, after I showed you that, I want to share this one with you, and I want someone to take a guess if they want to. They can put it in the chat, and they can tell me what they think. I'm not sure I'm going to be able to pull this off from an IT perspective, but I'll certainly do my best here. All right, hang on one second. All right. So this is a patient of mine, and this is an old video, but all right. So this person's asleep. You can see they wake up. All right, so what do people think about that one? Anyone want to make a guess? You can either unmute or just put it in the chat. I have not a seizure, sleepwalking, faking,
PTSD.
Yeah,
PTSD.
Looks like a nightmare with sleep paralysis.
Yeah, I would say PTSD.
All right. Well, a bad dream, not a seizure. This is great. I'm really glad you're participating. Thank you very much for participating. So this is why my job is hard and why I don't sleep well at night. That's an epileptic seizure. And that's a person who's got a very unique form of epilepsy that happens during nighttime. So it's a nocturnal seizure. And seizures that come from the frontal lobes in the brain sometimes just look a little bit different. The reason I show you that is to contrast that with the non-epileptic seizure, which just looked kind of bland. And then the first seizure that I showed you looked pretty scary. That one I just showed you just looks pretty scary. And this thing right here is weird looking, does not mean non-neurologic, and does not mean not seizures. So I adopt a pretty Zen posture about this. And I hear patients who tell me they do events where they flap their arms, or they shake their heads, or they scream out, or they crawl out of bed. And, you know, my job is to just kind of take a history. The reason I tell you this is that I'm seeing patients in a nice, comfortable office. I'm seeing people who are coming in who are now after the event, or even if I see them in the ER, well, they've already got a line in them and they're kind of taken care of. You all are going to be seeing people out in the field. That's a whole different world out there. And so if you were to see someone like that, if you came to a home, or if you came to, you know, an organization or something where you were called to do your job, boy, you might think that person was on drugs. You might think they were a crazy person. You might think they were having major psychiatric problems. The reason I want you to see that is just so in your mind, that differential diagnosis of could this be a seizure floats through your mind, because really that's just something you won't think of it unless you think of it. And that's my job. It's just to put this in there to say, well, wait a minute, before I think this is drug abuse, wait a minute, before I think this might be a psychiatric patient or aggressive, crazy person, wait a minute, maybe this is some bizarre kind of seizure. And it just gives you a little bit of pause in terms of how you engage with patients. So I want to talk to you a little bit about seizure first aid, and specifically not lecture you about first aid, because I know many of you have taken care of individuals in the field who have had seizures, and certainly there are strategies for how to do this. But I did want to share with you that again, to consider the possibility of seizures, especially now with the rampant use of drugs out in the city of Baltimore. We often see people walking down the street shouting and acting strangely and acting out and threatening people and sleep in the corner or on the nod or something. And it's important to realize that even though we have that, sometimes people who are not in their right state of mind, it's something else going on. And that's why it's just important that as responders that you think about the possibility of seizures, because indeed your action can be life-saving. The materials I'm going to show you, and I'll be happy to share the slides with you, they are on this website right here. And essentially, I'm just going to jump ahead real quick. This is what it is. It's from the Epilepsy Foundation. This is the published accepted first aid for seizures. Again, this is before you're going to be using rescue medications. And there's a nice hashtag, which is Stay Safe Side, and we'll talk a little bit about this. So in the field, a couple of tips and a couple of things to just keep in your mind. First of all, people who are having seizures are usually not actively conversant. So you're not going to get into a conversation with someone who's either harassing you or yelling at you or talking to you about, ravens or whatever. People are usually disoriented. If they're having a generalized tonic-clonic seizure, they're unconscious, they're not talking. Most people are not able to actually speak, or if they do speak, they're saying kind of gibberish or nonsense. One of my patients, for example, when he had a seizure, he would just go, mommy, oh, mommy, mommy, oh, mommy, mommy, oh, mommy. I had another patient who used to say, look at the ponies, look at the ponies, look at the ponies. So these are not people who you're going to engage in a conversation with. And if you're meeting someone and they're having a full conversation with you, it's highly unlikely that they're having a seizure. During a seizure, people may shout or vocalize. You heard the gentleman in the seizure I showed you. He makes this loud, scary cry. The name of that is actually called an epileptic cry. And I will tell you, as an epileptologist, once you've heard that sound, you will never forget it for the rest of your life. I've been on the hospital wards and I've heard that sound down the hall. And I said, oh, I know what that is. And I go running. They will usually, matter of fact, never have goal-directed violence. So sometimes I've heard about people blaming, grand theft auto, breaking and entering crime on a seizure. It doesn't work that way. People are having seizures. Their neurologic function is completely compromised. So they're not going to pick up a weapon. They're not going to start a fight with you or anything like that. They're usually disoriented and often terrified. They're often frightened. Think about it. Imagine you were out in the world and suddenly you became unconscious and you woke up and there's a whole group of people leaning over you that you don't know what happened. Maybe you bit your tongue, maybe you fell and banged your face. You're frightened, you're scared, and it's a very unpleasant event for them. After a generalized tonic-clonic seizure, people are often very lethargic, very sleepy. Sometimes they just want to sleep. After a seizure, as people begin to wake up, they can become aggressive. Now, when I say aggressive, again, I don't mean pulling a gun out and shooting you. I don't mean, trying to pick a fight with you. They're mostly like, get away from me, get away from me. It's usually because we as caregivers are kind of in their face. And it's a real hard thing to do when someone's had a seizure, to be kind of soothing and gentle with them and sort of say, hey, sir, what's your name? And, they say, Mike. And you say, Mike, listen, you had a seizure, man. You're going to be okay. You just got to relax and chill a little bit. That works way better. You can't kind of suppress them, hold them down. If you do, you may enhance that aggressive response. Many times people who've had seizures will want to walk or move after their seizure. And it's sort of part of the recovery of the seizure event. It's sort of how they kind of get back into themselves. It's okay that they do that. And sometimes the best thing to do, we run into this into the hospital all the time, is we get a doc or a nurse to just kind of link arms with them and just walk down the hall a little bit. And they'll slowly come back and say, okay, I had a seizure, right? I know what's happening. Obviously, this is a person who has a diagnosis of epilepsy and done this before. Person who's had a first-time seizure, I can tell you, they have no idea what's going on. And they're usually pretty terrified after the event has happened. So, all right, first aid for seizures. Some of this may be very basic for you, and I apologize if it is, but unfortunately, this is like the most important thing that we all consider. If you're seeing someone who's having a generalized tonic-clonic seizure when you're out working, the things that you need to do are really not that many, right? The first thing is you're going to be staying with that person. The second is maintaining the fact that they're safe and not injuring themselves or at risk of falling or getting hit by a car or something, and the ability to turn them on their side to keep them from aspirating their stomach or their oral contents. This is actually a nice little kind of a flyer that's put out from the Epilepsy Foundation. It's used really for laypersons, not people who have either BLS or ALS or any kind of EMT training. But again, it sticks with the stay, and I'll go through the safe side. Call 911 or realize that you're in a medical emergency situation. If someone's having a seizure lasting more than 5 minutes, if no matter what, they just don't start coming back, they still seem disoriented. If the person is a pregnant female who's had a seizure, absolutely get that person to the hospital, because remember, it's 2 lives, not just one. And then some other things, difficulty breathing. If you're out, if you're ever out in the pool or in the ocean or something and someone has a seizure, I've had it happen to me once. It's terrifying. That's the thing where you want to get 911. 2 things I want to put out here. Number 1, do not restrain people. You cannot restrain someone who's having a generalized tonic-clonic seizure. There's no way to slow it down. There's no way to stop it. It just quite simply has to run its course. Number 2, there is this old thing about when someone has a seizure to put a spoon in their mouth or put a stick in their mouth or put a belt in their mouth. Do not do that. All you'll end up doing is just breaking teeth and maybe losing a finger. So keep your fingers away from their mouth. All right, so stay. That's the first part of it. Stay with the person and start timing the seizure. It's hard to have the presence of mind to do that, but honestly, it really is important. Once you start interacting with them, you just kind of look at your watch, you can set your phone and just sort of realize that if this is going on for more than 5 minutes, this is an emergency. This is something that needs to be taken care of. It's important that you remain calm. I usually tell my residents, don't just do something, stand there. It's okay to just kind of stand there and just wait, right? Let this thing happen. We know what's going to happen. 80% of seizures will stop in 5 minutes. Everyone's running around like a chicken with their head off. It's okay to just let a person have a seizure. Again, check for a medical ID. If this person has a diagnosis of epilepsy, it will completely change the trajectory of how you're going to get them into the emergency medical system. Again, timing the seizure is important. If it's going on for more than 5 minutes, that's status epilepticus. It's a medical emergency. All right, keep the person safe. I imagine this is particularly relevant and cogent to your line of work and what you do in terms of being in a very unsafe environment. I'm not sure I have any particular wisdom for what to do if a person is in a building where there's a fire ongoing. Obviously, getting that person out of the building seems logical to me. That's the physician's perspective, not the firefighter's perspective. But the other scenario was sometimes people will have a seizure at the top of the stairs or on the side of the road. You want to get them away so they're obviously away from harming themselves. It's okay to move a seizing person, even if you just kind of have to scooch them out of the way. That's okay. I've moved many off the floor in the hospital. That's okay. Obviously, broken glass, sharp objects. A big one is fire and the bathtub. I've had countless people over the years who've had seizures and fallen into the grill, and no one knew what to do, believe it or not, and they just panicked, get them off the grill. Bathtub, I've lost one person to a bathtub drowning. It's a horrifying thing, and it does happen. Now, if a person's having a partial seizure, if you remember I said a partial seizure, they may be confused or disoriented. If they're out trying to walk into traffic, or if they're trying to walk onto 95 or something, right? Your job is to gently try to steer them away. You don't have to yank them. Sometimes just say, hey man, come, let's go this way, come on. Usually in the seizure, they'll go with you. They're not going to argue. Their mind is doing something totally different. And, this is a great example. Traffic, subway platforms, anytime, person is at height, and again, things like sharp objects, broken glass. The other thing is everyone has a natural tendency to crowd over everybody, get people to back up. A lot of times people after a first-time seizure wake up, they have no idea what happened. They're frightened, they're terrified. They may have a bit lip. They may have wet their pants, and they're just completely disoriented. And remember, you can always ask for help. People nearby can get supplies. People can call for additional assistance or additional help. Turn the person on their side. Why do we do this? Well, the simple reason is that during a generalized tonic-clonic seizure, patients will often bite their tongue and have a mouthful of blood. If you happen to be eating a Big Mac during your generalized tonic-clonic seizure, you will have a mouthful of Big Mac, and we don't want the person to aspirate, because now you'll have a seizing person who has an obstructed airway. That's definitely an emergency, and you've got 2 things going on. Good luck getting an ET tube down a person who's actively convulsing because their jaws are locked shut. Loosen tight clothes around the neck, so neckties, necklaces, etc. And in a person with a partial seizure, if you can just get them to sit down and be calm, remember, their seizure is going to stop in about 5 minutes. And if it doesn't, you got to get some help. You got to get this person to the hospital. If the person has had a seizure and they're sort of getting ready to fall, you can kind of help them fall to the ground. You can put something under their head. A lot of times people will bang their head on the floor. That's not good. And again, just turn them on their side, the mouth sort of facing the ground. If they do vomit when they wake up, it'll go out onto the ground. Many times people during a convulsion, this is important, it'll look like the person has stopped breathing. And the reason is that during the convulsion, the chest muscles are in the tonic phase. They're not moving any air. When the person stops seizing, they will usually do something like this. They will go and take a gigantic breath and then start to breathe in and out with very, very kind of gravelly respiration, lots of phlegm, and it'll be like, there's actually a name for it. It's called stertorous respirations. And interestingly, it's such a robust finding that in the hospital, we often use it as a way of telling whether someone's having a real seizure from a psychogenic seizure. People who have psychogenic seizures never, ever do that. When they wake up, they just kind of wake up and pop out of it. Nobody ever has a grand mal seizure and then stands up, dusts themselves off and says, oh, that sucked, and walks away. Never, ever. They're always out of it. And so there is a little bit of time that you're going to have to get this person back. Rescue breathing is usually not needed during seizure-induced changes. Now, as first responders, people who are BLS trained, if someone wakes up from a seizure and they've got no pulse or pressure, well, it's a whole different algorithm now. Now you're doing CPR. That usually doesn't happen as a general rule during a convulsion. There have been studies on this. Most people, if anything, are wildly hypertensive. Their systolic blood pressure is 200. So they're perfusing their organs just fine. But if someone stops having a seizure and it's like, hey, they're not breathing, and then you check for pulse and you can't find it, well, now you just go into the BLS algorithm. Again, don't put anything in their mouth. Another thing, I'm pretty sure I don't need to tell this group, but it is anatomically impossible to swallow your tongue. But your tongue is the leading cause of an obstructive airway. So you can easily obstruct. And if you put a Big Mac in there, it's very, very easy to do that. The other thing is in the setting of now getting to sort of the idea of rescue meds, you know, oftentimes we put rescue meds in the buccal space in between the cheek and gum and the cheek and the tooth. So, you know, you don't want to be sticking things in there. You want to be able to have a nice, easy access to slide an Ativan or a Midaz in there or something like that. Don't give the person any water. They'll say, can I take my pill? Don't do any of that until they're fully awake, sitting up and kind of conversing with you. Again, don't restrain people. If you try to forcibly hold them down, you're only going to probably injure yourself and them. I will tell you that the force of a generalized tonic-clonic seizure, the first seizure that I showed you, is enough to spontaneously break bones. I have seen over the years fractured clavicles, fractured spinous processes. Just the sheer force of the muscular contraction is enough to fracture a bone. Unfortunately, there's just nothing you can do while this is happening. You can't make them stop by leaning on them. Just to remind you, right? Stay with the person until they're coming back. If they're not coming back, then that person needs to be taken to the ED for further evaluation. As I said, injury is very common during seizures, whether it's burns, falls, broken teeth, broken bones, lots of broken noses over the years. You know, again, if a person comes out of their seizure and they do have a mouthful of food and it now sounds like they have aspirated a bolus of food, or if they have food and tongue and blood and mucus occluding their airway, well, again, this isn't a status epilepticus algorithm. This is an airway algorithm. And now you're trying to basically clear this person's airway, trying to rescue breathe and really get away so you get the person so they can have rescue respiration, which in fact could require intubation in the field if they have an occluded airway. Something just in terms of general empathy and clinical care, most people after the seizures are pretty frightened. Even epilepsy patients, they wake up, they're embarrassed. They're like, I can't believe this happened. I stopped for a crash on Interstate 295. I actually watched this guy drive by me convulsing at the wheel, believe it or not. What are the chances that a tertiary care epileptologist is driving down the road and a patient drives by convulsing? And he wrecked his SUV and I stopped and went over and, you know, he was okay, but he was really embarrassed and he was just like, I can't believe that happened. And so a little sensitivity to realize that people may not really know what's going on. If it's a first-time seizure, you're really going to have to talk them down a little because they will not know what it is. And you'll say, look, sir, I think you might have had a seizure. We're going to get you some help. Sit down. The best thing you can do is relax. And really, that's all you can do until you can get them into the emergency medical setting. I wanted to show a couple of headlines. This is not in any way a shot at law enforcement at all. This just appeared in one of our medical journals. And I actually gave, when I was working in Philadelphia, I gave a talk to the Philadelphia Police Department about this, which is the appreciation of epilepsy as a diagnostic consideration in individuals who present with disorientation or confusion, and not mistaking them as individuals who are violent or doing criminal acts. And there have been a number of these cases of complex partial seizures where people do things like scream, run, shake their arms and legs, do weird movements with their arms. If law enforcement is called to see these individuals and don't know about the possibility of seizures, it's very easy to misinterpret these behaviors. Now, that one seizure that I showed you of the person with a frontal lobe seizure, if you saw someone doing that on the street, you'd have no idea what they're doing. And yeah, you might think about tasing them and handcuffing them. And in fact, unfortunately, this has actually happened quite a few times. And as I mentioned, after seizures, people can become a little belligerent, a little aggressive. And so it's important to have a gentle touch. Even in the hospital, I do this. I have kind of a gentle touch and try to talk them down from the ledge a little bit. This is from the Indianapolis Metropolitan Police Department. A gentleman had a seizure, was confused and disoriented afterwards. He ended up getting tackled, tased, handcuffed, and he was having a seizure. This is from Michigan. This is a gentleman who was seriously injured after a seizure and was having sort of bizarre involuntary movements, and he actually ended up having a brain injury when he was tackled and cuffed. So just be mindful of that. That when you see somebody, that violence and force doesn't usually work, and people who are having seizures, they're not going to do you harm in the sense that they're going to come after you. They're confused and disoriented. They don't actually know what's going on, and your job is to steward them to safety so that they're not going to hurt themselves. So we've had a number of questions about rescue medications, and I don't know, Sean, if you want to discuss this at all. You mentioned something about a protocol in terms of what's offered for the Baltimore County Fire Department. There are a number of rescue medications that are used. Typically, we use them in individuals in the field who are having seizures lasting longer than 5 minutes. So really de facto people who are having status epilepticus. They're usually oral, so they can be put under the tongue. They can be put in between the cheek and the gum. So either oral or sublingual. So oral is in the mouth, sublingual is under the tongue, buccal is next to the cheek. There is a formulation of diazepam, which is Valium, which is known as Diastat, and that's given directly into the rectal mucosa. It comes in a syringe, and it works very well. Obviously difficult to do in the field if you have to get lots and lots of clothes off. And then the most recent development has been two new medications. One is an intranasal midazolam, which is marketed as Nasolam, and the other is an intranasal benzodiazepine, which is diazepam, which is marketed as Valtoco. They're both single dose shots up the nose, and they work terrifically well. So I don't know, Sean, to what extent the fire department is using these medications as part of their protocol or not. I'm happy to discuss each one of them. The list of the meds here are Diastat, which is the rectal prep, Nasolam is the nasal, Valtoco is the diazepam nasal spray, and then people sometimes use lorazepam, which is Ativan, in between the cheek and tongue.
I know Dr. Pollack's online. He may have a broader perspective. MIMS has protocols for both midazolam and Valium.
Gotcha. And that's in the individual who's found actively convulsing. Is that what the plan is?
That's right.
Okay, very good.
And more than 5 minutes. And we can share the protocols.
All right.
I can share.
So I've been going on and on. I hope it's not been too much information, but it's a little bit of a complicated topic, and I wanted you to get an understanding of just not what happens in the field, but to understand a little bit about the disease and just the syndrome a little bit, and realize that it's a very common syndrome. It's a very common disorder that really alters a lot of patients' lives. It requires lots of diagnostic evaluation. If you have epilepsy, it's often a lifetime commitment to medications and medication levels and MRI scans, and it really is life-altering. A first-time seizure, yes, can just happen to anybody, and it's benign and it doesn't mean anything, but it can also have a grave prognosis and mean that you've had bleeding in the brain or you have a brain tumor. So it's really, really full spectrum. behaviors that are aggressive, abnormal, odd, or confused, even though we look at them, we say, what is that person doing? Why are they doing that? Oh, that person's high on drugs. Well, maybe, but maybe not. And only if you just pause for a minute and say, well, wait a minute, I heard this talk once about seizures. Could this person be having a seizure? At least let it run through the list of possibilities in your mind. And then the simple, I think, stay safe side, stay with the person to keep them safe and get them so they're out of way of harm. If they're having a generalized tonic-clonic seizure, turn them on their side so they're not at risk of compromising their airway. If a seizure goes on longer for 5 minutes, either be prepared to deliver a rescue medication or to call 911 or activate EMS to get the person to the hospital. And that realize that you're going to have to sort of be with them for a little while until they begin to come back to normalcy. So I will stop there. I have on my clock about 8:09, and I certainly could do some time for questions. If people want to just ask the questions, we could do that. If they want to put them in the chat, I'm happy to stay around for a while.
I have a question.
Yeah, sure, Dr. Pollack.
Pete, thanks very much for this talk. This was absolutely fantastic. I really appreciate you coming. And
Thanks, Andy.
thanks to Sean for putting this whole thing together. Question for you. A common scenario that our providers are faced with is you have somebody who has a grand mal seizure. By the time we get there, it's typically more than 5 minutes. And as you point out, seizure done in 5 minutes and the seizure's over and the patient's waking up and actually getting better. And quite a few of them will actually decline transport to the hospital. What's the risk in that situation? Because what we teach people is that it's probably better to really encourage people to come in just to be observed for a little while to make sure you don't seize again, to make sure that we've got appropriate levels of medications and that other things don't need to be adjusted. Can you talk a little bit about the risks of leaving somebody in that situation?
Sure. So it's a common question that we get actually also, right? I have patients ask me that. Do I have to go to the ER every time I have a seizure, and it happens at home? And think about, for those of you here, how many of you have been to the ER recently? Going to the ER, it sucks, right? You're there all day, you're waiting all night. And you end up getting a line and you see a bunch of doctors and nurses and then you never know what's going on. So the thing is this, if you see someone who has a medical alert bracelet that said that they have a diagnosis of epilepsy, if they're coming out of it and they say to you, honestly, thanks, I do this twice a week. If you can convince yourself that they got someone that they see, if you say, do you have a neurologist that you see or do you see a doctor? If you convince yourself they're a reasonably responsible person, you probably could say, all right, you have epilepsy. The condition of epilepsy is defined by having recurrent seizures. We know you take meds, you had a breakthrough seizure. You're probably not going to do something wrong if you do that. The safest thing to do for every patient, of course, is to bring them into the ED because you're going to do things like check metabolites, make sure that their electrolytes aren't abnormal. They're going to check drug levels. They're going to get a CT scan of the brain to make sure that when they fell, they didn't get a subdural or a subarach or something. So, I don't think you have to get into a big argument with a patient. If it's a first-time seizure, there is no argument. Every first-time seizure goes to the ED, period, non-negotiable. And I maintain that. I've maintained that for years. It's just more challenging in the person with lifetime epilepsy. I have people, as I said, who are on 5 seizure medicines who have 3 seizures a week. This is just daily practice for them. And they're like, crap, I was out at the mall and I had a seizure. Do I really need to go to the ED? Probably not. But for a first-time seizure, absolutely. And if you're not sure, absolutely.
I have a question regarding the patient who woke up in the middle of their sleep and had a seizure. Is there any type of medication that helps control that type of seizure?
Yeah, so that's a really good question. And unfortunately, those kinds of seizures are really tough to treat. And there's no particular medicine that works. There's actually often a genetic cause for that type of epilepsy. And it's a tough scenario. Many times those individuals will go for epilepsy surgery. So that's a person who's got such a dramatic clinical event that's clearly disrupting his life. Not to mention the life of his spouse who has to deal with that like 3 nights a week, by the way, that we often refer them for epilepsy surgery. But no, sadly, there's no particular medicine. Now, in the chat, somebody mentioned as a possibility a parasomnia or sleep terrors, you know, like the other is something called REM sleep disorder, which is you act out your dreams. And that's on the list of possibilities. And so a gentleman like that, we would admit to the hospital, we would hook them up to EEG, and we'd monitor them for several days to actually see what these events look like, show that they're epileptic seizures, and then make a plan for either medications or for surgery. But no, that's a particularly tough epilepsy syndrome.
I've got a question.
I'm sorry, go ahead.
The idea of not trying to restrain someone having a seizure, what did you think of the restraint that was used on that patient that we're talking about who woke up and an orderly or somebody just landed on him and did a full?
Yeah. So that was actually in an epilepsy monitoring unit. And that was at University of Pennsylvania where I was before I was here at Maryland. And there, when they see a person who is going, you know, bonkers off the wall, our epilepsy techs and nurses will actually often go in there and throw themselves in the way of harm to try to protect the patient. It's pretty noble, actually. She went in there, I think, to be honest, if I remember this, she went in there not intending to be sort of locked in an embrace with him. I think she was intending to kind of just sort of calm him down. I think she kind of actually fell on him, and the two of them kind of fell together. As a general rule, no, we don't tell our nurses to lay on top of patients who are having seizures. But sometimes it does happen.
Thank you.
Yeah, sure. Should I go into the chat, Sean? There's a bunch of questions, or what would you like me to do? I'm happy to go through the chat. There's a
feel free to go through the chat, sure.
Sure. Here, okay. Oh, good question. So people who are prone to seizures, can they drive or are they not able to? Yes, they're absolutely able to drive. Each state of the 50 states has its own unique driving laws. So in the state of Maryland, there is not mandatory physician reporting for a seizure. However, a person is supposed to, when they go to DMV, they're supposed to, when they fill out a form for their license, they have to check a box if they ever had an event of loss of consciousness, which includes syncope or a seizure. Then it's up to the DMV to decide whether the license is going to be given to that person. In the state of Pennsylvania, the state of New Jersey, the state of Delaware, just because they're close by, there's mandatory reporting. So if a patient comes to me with a seizure, by law, I have to report them to the DMV. Again, I don't take their license away. The DMV takes their license away, but I have to fill out a form that says, yes, this person has epilepsy. Yes or no, I think they're controlled. And yes or no, I think they're safe to drive. Jersey, it used to be 1 year you were suspended if you had a seizure, which was brutal. Now it's 6 months. Delaware's 3 months and Pennsylvania's 3 months. Would the use of an AED creating an electrical current impact affect the RNS device? So remember that implanted device? Yeah, you can't go through the security devices at the airport. It'll cause it to go off. So you have to go around. It's similar to having a cardiac pacemaker. Other electrical devices, I don't think so. Microwaves though do. Even the new forms of microwaves mess up the AI there. Is there a typical length for the postictal state? Robert Gold, fabulous question. The postictal state can be literally 30 seconds to days, believe it or not. We've had people who've come in after a really bad first-time convulsion who are still not quite right 48 hours afterwards. We end up hospitalizing them, and you come in and they're just still a little confused, a little foggy, a little slow. That doesn't mean they necessarily have to stay in the hospital, but you know, after a major electrical discharge like that in the brain's a little messed up for a while. Some people, after they've had lots and lots of seizures, if they have epilepsy, they come back right away. There is another thing that's a little frightening, which is in children. This has been shown. Children with recurrent seizures actually have a fall of IQ points that is directly proportional to the number of seizures per month. And there are children who've had drop in IQ points of over 20 IQ points when they have recurrent seizures. So yeah, seizures are bad for the brain. In addition, if you're having convulsions, you're not breathing, so your brain is actually not getting oxygen. So that's bad for the brain. Your blood pressure goes through the roof. Your intracranial pressure goes through the roof. So in general, it's a bad engagement for the human brain. And by the way, thank you. Many of you put some very kind words here. Thank you for the kind words. I really appreciate it. Oh, here's a good question. Two of them together. How do flashing lights cause seizures? And what about playing video games? Used to be a big trigger. So The flashing light seizures only affects a certain population of people who have a genetic type of epilepsy. And believe it or not, the flash has to be at a certain frequency. So the current video games now, even they put the disclaimer down there, like, PlayStation and Xbox aren't going to do it. Some of the games that came out, if you remember, it was in Japan, they had a certain flash frequency range. They were triggering seizures. People who have a genetic tendency to have seizures will flash. Boy, let me tell you, if they go to a dance club and there's the strobe lights, or they go to a stadium and there's strobe, they will have a seizure. I had a patient I'll never forget who used to tell me when she would ride in the car on a sunny day, if the trees were flickering, the sun, she could trigger a seizure herself. Any value to blow by O2 during the seizure? Definitely. Yeah. If you can get in the hospital, we have a protocol for a witness convulsion in the hospital. We put on 100% non-rebreather on that patient, just because when they take that first breath, we want to get O2 in there, and maybe some of that O2 is getting in there during the seizure. Probably not very much. They're not moving much air. Someone says, I had an elderly patient who presented with a constant straightening and flexioning at the elbows on both arms. Patient was conscious and alert, but she couldn't control her arms. This lasted the whole call and continued with the transfer of care. Does this patient require midazolam since it is lasting more than 5 minutes? So that's a tough question, because there's other things. There are certain movement disorders that can look very much like seizures. I think if you're not sure and the person is awake and communicative, I would not use a rescue med. I would get that person into the hospital, especially since you could probably get them pretty rapidly. They might even be able to get a neurologist to take a look at them, and you would avoid giving them midazolam unnecessarily. I think I got all the questions in the chart. Did I miss anyone's questions? I'm sorry. If I did, please shout them out.
Yeah, there's a question about an elderly patient who presents with a constant straightening and flexioning of the elbows and the arms. Do you see that?
Oh, I'm sorry. I just answered that. Did you guys not hear that? I'm sorry.
I'm so sorry. I was chatting. That's all.
Did you hear that, Andy?
Yeah, we heard it.
Okay, great. Yeah. You don't know, we have people who have what are called movement disorders. So they have tremors, or they have things where their arms jerk like this. It can look like a seizure, honestly. And so if that person's talking to you and saying, Doc, sir, I don't know what this is, I wouldn't give them a rescue med, because you just don't know what it's going to do. And you get them in the hospital and get someone to take a look at it, make sure it's not some weird movement disorder. There's a famous movement disorder, which is called, it's called hemifacial spasm, which is just half the face twitches, and it looks just like a seizure, but it's not a seizure. And we know because we hook the person up to the EEG, and there's no seizure going on in the EEG. And so that's just a different kind of strategy.
I have a couple of questions for you.
Sure.
First of all, I have a son with epilepsy.
Oh, okay, great. Thank you for sharing.
On many occasions when he was in high school, he would have seizures in gym class or following gym class because physical activity seemed to exacerbate the seizure.
100%.
And at one time, his gym teacher noticed that he was kind of like a zombie and knew he had epilepsy and had a feeling that the seizure was coming on. So he put him down on the floor, and he did have a grand mal seizure.
Yep.
Is there anything that he could have done to prevent it from progressing, or once he's a zombie, he's going to go full tilt?
Yeah, that progression from sort of the partial seizure where you're kind of just staring and not looking right to an actual convulsion is a very delicate calculus. And as I said, even in the hospital, sometimes we see people, we try to get them out of van. We just can't get it in fast enough. And even sometimes when you do, the brain is already decided. It's already going to go full generalized convulsion. The best thing that
coincidence that it happened after physical activity, like
No.
riding a bike or running on the track?
Not at all. Actually, there are certain epilepsy types. And if you want to email me, I put my email here. I'm happy to put this in the chat, but here, I'll send it out to everyone. There are certain epilepsy types that are triggered by fever, body temperature increase from exertion, overly warm clothes, and just physical exercise. It's a thing. We see it.
The other question I have is I get calls lots of times for people who quote had seizures. And when I get there, I suspect they may have had an arrhythmia.
Oh yeah.
If they're not postictal, is it not a seizure?
No, that's a hard one. I mean, I think you have to get a good sense of what the person actually did. And it gets back to the question of, Andy Rose, which is a great question. Probably those people need an evaluation in the hospital. This isn't a field evaluation, a field triage. This is, if you get there and someone said, geez, I had this funny spell where I was just really, really lightheaded and dizzy and they're holding on and like, I think I'm okay. That could be 10 different things, a few of which are actually pretty serious, right? So a TIA, a transient ischemic attack, cardiac dysrhythmia, maybe they had a seizure. That kind of evaluation, the best triage you can do is to recognize it and get them into the hospital.
I had a 33-year-old female who had that kind of an episode, and we got her to the ER. She was in second-degree heart block and ended up with a pacemaker.
Absolutely the case. And cardiac dysrhythmia is on that list of things that people, we have the EKG running when we run the EEG. It's amazing the number of people will have spells that were diagnosed as seizures, and it's like AFib, it's like second-degree heart block. And yeah, so, it's sometimes it's not the brain, sometimes it's something else. The question here is, does cold weather trigger seizures? I have seen cold days with several patients seizing. Not particularly that I'm aware of. No, I can't say that's necessarily true, unless there's some other, comorbidity or something, but just temperature too cold. Actually, cold usually shuts seizures down, as a matter of fact. Amazing thing in the operating room, when we open a person's skull to do epilepsy surgery, if we just squirt ice cold saline on the surface of the brain, it stops seizing immediately. It's pretty amazing, actually. Here's a question. Are there olfactory triggers to seizures? Yeah, there are. So there are a family of medicines that are called reflex epilepsies. I'll tell you the craziest reflex epilepsy I saw. I don't know if anybody remembers, there was an old time song many, many years ago, and I'm going to sing it. I have a terrible voice, but the song went, I'm walking in rhythm. Okay. This person only had a seizure whenever they heard that song. And when we first evaluated him, we said, oh, come on, that's impossible, right? Sure enough, we brought him into the monitoring unit. We popped the tape in, boom, bang, convulsion right on the spot. And it turns out there's a whole family of genetic epilepsies that are called reflex epilepsies. And smells, sights, sounds, tastes, people. We had a young man a few years ago who had something called pill swallowing epilepsy, where every time he swallowed his pills, he seized. And we thought his mom was making it up. We were like, oh, come on, that's impossible. Again, hooked him up. Bada bing. So I get very zen about this. People tell me they're having spells. I go, okay, come on in. We bring you in, we hook you up. And every year I see something new. So yeah, for sure. So here's a good question. This may be a silly question. I'm new to the fire department. It's not a silly question. What are grandma seizures? It's not grandma. I will write it out because it's often misappropriated. It's actually grand mal seizures, and it just means really bad. It's an old-fashioned terminology for a convulsion or a generalized tonic-clonic seizure. That was the seizure that I showed you, the first thing, where the man was shaking all over like this. They used to be called grand mals. Every now and again we slip and we say grand mal. It's still a pretty good term, but the actual medical term is generalized tonic-clonic seizure. Other questions? I think we covered it all.
Crino, thank you so much. Thank you for entertaining all the questions. Thanks for a ton of information and all the stories, right?
Oh yeah, well, it's been a crazy 30 years, I gotta tell you. And ma'am, I wish you the best with your son. I hope he does okay.
Thank you
Thanks,
so much.
Pete.
Dr. Pollack, thanks for your support and thanks for bringing him to us tonight.
All right, everyone. Hey, listen, stay safe and thank you for all of your dedication. We really, it's a very noble thing you do. Thank you so much.
Thank you.
See you guys. Bye-bye.
Stay safe.